Good day to all, and welcome to all the participants. So, Jean, you start first. Okay.
Yes, I will start. So,
Okay.
ladies and gentlemen, and welcome to our AFOMP school webinar. I think this is our seventh webinar for the AFOMP. So today's topic is imaging techniques in medical physics. Let me first introduce our moderator today. So it's all honor today for us to have Professor Dr. Hasin as our moderator. Helen is the vice president of the AFOMP, professor and the former director of the Center for Biomedical Science and Engineering in the United International University. Professor Hasin has been published more than 70 papers in various conference proceedings and book chapters, scientific articles, both in international or national journals. Also have some reports in various programs like International Day of Medical Physics, International Day of Women and the Girls in the Science. She's also lots of membership of lots of international associations like IOMP, ISCHO, and AAPM also. So now I will just welcome Professor Hasin to do the modeling today. Thank you.
Thank you, Dr. Jean Chiams. And good day to all, and welcome all the participants. You know, AFOMP school is every month we have one AFOMP schools, and we carry the 6 CPD points for each webinars. And we do very interesting and the challenging topic, which is very needed for the AFOMP regions and beyond the AFOMP regions medical physicists. So today's topic is imaging techniques in medical physics. And the thing is that we have a very prominent and very expert speakers in this field from Korea and Germany. So we have with us Professor Dr. from Korea, Professor Dr. Seungryong. I share my screen. Dr. Seungryong Cho. I am giving all the introduction of them, so you can see their biodata and their experience in the field. So I think it can be seen. So see, that's our first speaker is Dr. Seungryong Cho, and he has education is PhD in medical physics. And also he has had the committee in the Medical Physics University of Chicago, USA. And then he has a many professional experience, especially in KAIST, as a professor, Department of Nuclear and Quantum Engineering, as well as the Director Center for Radiological and Nuclear Medical Research, KAIST. Till now, he is working as a professor and director in the KAIST. He is the editorial board member in Physics in Medicine Biology, associate member of Medical Physics till now, SPIE Physics of Medical Imaging Conference Committee member till 2021, and General Chair International Forum on Medical Imaging. He has many research interests, especially on physics of X-ray imaging, particularly including computed tomography, novel image reconstruction algorithms for various medical imaging modalities, advanced radiation therapy with image-guided techniques, non-destructive testing for industrial applications, as well as image processing and analysis. So today, he will be the first speaker, and the next speaker is Dr. Diploma Engineer Kathrin Entz. She is the head of medical physics of Diagnostic Radiology Department, University Hospital, Frankfurt, Germany. She has done in Diploma in Biomedical Engineering in his career in the field of healthcare, as well as master's program in medical physics to pursue in medical physics as well. After graduation, Mr. Anss joined the University Hospital in Münster, specializing in physico-technical quality assurance for the German breast cancer screening program. And since 2019, she is working as a head of medical physics in University Hospital Radiology Department in Frankfurt. Her focus of radiation he dedicated to education and training for radiologists and radiographers, as well as she has served as a lecturer at the School of Radiographers in Münster and for the German Radiological Society. Quality assurance, she has made a pivotal role in quality assurance, especially for diagnostics, actively contributing to the German Standard Committee's work. She is the chair of the Terminology Committee and elected in 2022 as a chair, and further highlighting her leadership and influence in the field. So welcome to Engineer Kathrin Entz in the webinar. The last speaker is the Professor Dr. Golam Abu Jakaria. He has studied in physics in University of Halle-Wittenberg as a diploma physiker, which is equivalent to master's degree in physics, especially in medical physics in 1978. Also done the postgraduate study in a university hospital of Göttingen University, Germany, and PhD in the University of Heidelberg. She has professional qualification, accredited medical radiation physics in radio-oncology, nuclear medicine, and radiological diagnostics. He is the fellow of IMP, DGMP, Bangladesh Cancer Society, and Academy of Science. Recently, he has awarded in 2023 the honorary membership of German Society of Medical Physics, DGMP. Also, he got awarded in 2019 the Global Radiation Oncology Award from the Harvard Medical School, also from the Serb Federation of Oncologists, the Outstanding Personality of the Decade for unique contribution to establish medical physics in Bangladesh. She is the founder of Medical Physics in Bangladesh Education, and also for prevention and diagnostic areas. He has worked in many areas like IMPCB. He is the nominated chairman of Accreditation Committee of IMPCB, also honorary advisor of the National Institute of Cancer Research and Hospitals, Bangladesh Cancer Society, and chairman of the DGMP task group for the developing country. So now we'll start our now the first speaker will talk on X-ray digital breast tomosynthesis for cancer screening and diagnosis by the Professor Seungryong Cho. Second speaker will talk with the imaging of pregnant women. And third speaker, Professor Jakaria, will talk on quality assurance program for diagnostic computed tomography. So every speaker will have make a question after speech. We'll provide your questions. Especially, please write to whom you are doing the questions. And now every speaker will give 40 minutes talk, and then we'll have a question answer session. So I will request Professor Cho to have his speech on X-ray digital breast tomosynthesis for cancer screening and diagnosis.
Thank you very much, Anupama, for your kind introduction. I'm going to share screen. Okay, before I start, I'd like to ask your understanding. On the way to my office this afternoon, I had a little problem. My car was broken. My car stopped on the road, and I was kind of panicking. So I think after the session, after 3 talks today, I think I'm supposed to participate in the Q&A, overall Q&A session, but I think right after my talk, I have to leave to work with the insurance people to repair the car. So I apologize, but I'm gonna wrap up my talk, and then I'm gonna have I'd like to have a Q&A briefly right after my talk. So please understand. Today, by the way, it's my great pleasure and honor to be invited in this webinar. Today, I'd like to talk about our recent work on X-ray digital breast tomosynthesis, or DBT, for cancer screening and diagnosis. It's more like a technical aspect of new techniques that we have developed to improve image quality and to address some limitations of the existing DBT systems. Okay, so here the outline. And briefly talk about the DBT, what is DBT and baseline image reconstruction. And due to the imaging physics, there are going to be image artifacts, which we try to address and reduce. And I'm going to talk about synthetic mammogram that is necessary for clinical applications. And the following 3 and 4 are more like an applications, including deep learning technologies. And if I have enough time, I'm going to also talk about the fused imaging modality, which is DOT, or optical tomography with DBT, to increase the diagnostic accuracy. So on the left panel here, you see an example mammographic image and tomosynthesis image. You can obviously see that the lesion is more kind of clearly visualized on the DBT slice image, because DBT can provide a multiple slice images along the depth direction. It is supposed to provide a better visualization of structures that are usually overlaid on top of each other in a conventional mammography. Okay, and typically the source is moving around within a limited angle with a detector that can be stationary, or depending on the system vendors, that may have a rocking mode as well. This is an example of Siemens system. And why do we need DBT? Assuming that the recall rate and cancer detection rate to be normalized by 1 in a digital mammography exam, what are the benefits of using DBT? Here in this study, they show that the recall rate can be reduced by about 15%, and cancer detection efficiency can increase by about 20%. So it means that out of like 6 patients, 1 patient can be more accurately diagnosed. Eventually it can help save lives of patients. And reducing recall means we don't need to go for following kind of biopsy, which is invasive and painful. So DBTs are getting more and more used in diagnostic purposes or screening purposes for women's breast imaging. And again, X-ray source is moving around, taking projections in a limited angle. And conventional image reconstruction algorithms are based on filtered back projection. As you can see from a certain source position, you can acquire the projection data, as an example shown over here. And if you move around the source position, and then you can get the image accordingly. And using these acquired projections, what we typically do is you apply ramp filtering. Means as ramp filtering is enhancing rather high frequency. This is actually showing a ramp filter. The horizontal axis represents the frequencies space, and then the ramp type of the filter means you are rather emphasizing the high frequency. So as a result, from the given projections, applying ramp filtering would result in kind of edgy enhanced images, and then back projecting them to the image space like this would result in the image that finally you would be able to see. But obviously you can see, due to the limited angle scan nature of the DBT, the back projected images are everywhere, not only in the focused plane, but also off focal planes. So that is the problem indeed. What we want to see is, we want to see clear structure information here in the in focus plane. But you know, unfortunately, we will see a ripple artifacts, which is due to the high density object above or below the focal plane, and also due to the ramp filtering nature, this dark band near the high contrast or high density structures would propagate through as well. So we typically call these two artifacts by ripple artifacts and undershoot artifacts. And we wanted to remove these artifacts as much as we can. So the first thing we did is we used a different image reconstruction algorithm than filtered back projection. And it has been known that in CT community that you know, FBP in terms of mathematics is exactly equivalent to BPF algorithm, which is a short term for back projection filtration algorithm. So I'm going to explore a little more in the following slides. Particularly, this ripple artifacts and undershoot artifacts are going to be a big problem when you apply DBT system for biopsy. It is often needed that you have a needle to take the sample in biopsy, but you have to localize where you are going to get the sample exactly. So typically, we have an aid from an image guidance system, and DBT is a good candidate for providing the depth localization of the target. But because the needle is a high density object, if you take the image, it's gonna create a lot of ripples and undershoot artifacts. So this is a kind of a potential applications, one of the applications that we are aiming at. So here I show you some example of image artifacts like ripples, and also you can, if you look at carefully, there are undershoots nearby the high density objects. And this is an image of a physical phantom that is often used for quality assurance testing in a DBT system. You can see these are kind of bar phantoms for special resolution assessment. But you can see these dark bands, which is undershoot artifacts. And if you move around different slices, you can obviously see the ripples. And here you can see those ripple effects here. Those circular or triangular shapes are not in focus object, but it should show up in a different slice. But due to the ripple artifacts, you have this kind of confounding image artifacts. So people have worked on kind of various ways to removing these ripples or undershoots. One of the methods people have worked on is using a kind of a voting strategy. It's kind of simple idea that in the image space, you simply count how many times a given voxel has been sampled. For example, because usually the artifacts are related to the high density object. So you count how many times high density object back projection has been contributing to this given voxel. So for example, this yellow voxel has 3 counts from the 3 source positions. So we can say that this is true position of the high density object. So you keep them. Or in the green colored voxel, you don't have any count. Oh, I'm sorry, you don't have any vote, which means it's nothing but the background. So it's intact background. But the problem occurs in the red voxel because you have only, in this case, you're going to have only a single vote from this source position, but still the image would have a ripple artifact. So the point here is, since we know the number of votes, so for example, for this red voxel, we ignore the contribution of this back projection, because we know this is going to be due to the artifacts. So we apply this kind of a condition to say that whether the given voxel is in true in-focus slice or not. Doing so, we can reduce the image artifacts, but it's not perfect. What we focused on is we wanted to, I'm sorry, let me go back to this list. So one of the problems in this voting strategy is as the high density object becomes large and particularly flat, then it's gonna be likely fail, because as you can easily see, hopefully you can see the laser pointer here. The position over here would all have vote number of 3 votes here, right, up and down. So mostly up and down over here, the artifacts are not gonna be removed. Okay, so we noticed that this is due to the back projection nature of the high density structure. What we noticed is that in BPF algorithm, the process is like this. In a given projection, instead of applying ramp filtering, you first apply data derivative along the horizontal axis. So taking derivative like that, then you can get the only the edge images of the component, particularly the high density object, and then back project to the image space. And as you can see, we are not dealing with the volume or the high density object itself, but we are only dealing with the edges of them. So applying the voting strategy here in the DB or back projected image, it's more likely that you can clearly point out where the true edges are, right? So here, for example, the red points, the laser pointer mark would show number of votes 3 of the edge images. So that's truly an edge. Likewise, here also it's considered a true edge. But other areas are gonna have a less than 3 votes. So we are gonna completely ignore those boxes that have less than 3 votes. That way we can truly localize the edges of the high density objects in the in-focus plane, thus removing the existing artifacts in the conventional voting strategy. And then mathematically, we have to apply kind of a mathematical equivalent to ramp filtering in the image domain, which is known to be Hilbert transform. So once you apply Hilbert transform of this back projected image, then you can get exactly the same or mathematical equivalent image to the filtered back projection image. But you have a more chance to remove these artifacts because, again, you're gonna apply the voting strategy in these edge enhanced images. Okay. So that helps both to reduce ripple artifacts and undershoot artifacts, the details of which I'm gonna just leave in the slide in the sake of the presentation time. So I'm just showing you the example of in-focus back projected image on the left panel. And here, DBT case, you can see these on the edges are going to be highlighted. And out of focus, a lot of ripples and the residues are shown here in the conventional back projection, but in the differentiated back projection case, it's minimized. We had a little bit of image processing to fuse these 2 images to address the dark or undershoot image artifacts. Because here we still have, even after applying Hilbert transform, we're going to still have undershoot or darkening artifacts around the high density object. So to remove this kind of thing, we kind of segmented these true edges, and then we went through kind of 2-path approaches. So applying Hilbert transform for the background image, we can reduce or remove this undershoot, and then since we know where these artifacts are, we can fuse them using the localization information, so that eventually we can get crystal clear image of the high density object only. And for testing the idea or the algorithm in a realistic case, we used a port phantom with a lot of needles inserted inside. First, I'm going to show you the physical phantom case. On the left, this is the result of conventional filtered back projection. As we have seen earlier, there are ripple artifacts, and also there are undershoot artifacts over here. As a comparison, we also implemented a weighted filtered back projection, which is another kind of algorithm to address these artifacts. But it has successfully removed the ripples to a certain degree, but the undershoots are still there, or even worse. But our proposed method both address the undershoot and also ripples. Here again, you can see conventional algorithm shows a lot of ripples. Okay, in focus plane there should be a ring, and other planes there should be no rings. But a weighted case, you have even more degraded kind of undershoot artifacts showing up here. But the proposed method, compared to these two, has successfully removed the ripple artifacts and also undershoot artifacts. Also, I'm sorry, yeah. This is the pork phantom case. So conventional case, you have a lot of residue images of the needles, and weighted scheme has a lot of darkening, but our proposed method is a very sharp image in the in-focus plane and very reduced, much reduced image artifacts in the other planes. Okay, so this is one that we have developed for reducing high-density object artifacts in DBT. And since DBT is going to deliver a similar amount of radiation dose to the mammography, so it is advised that a DBT system can provide a synthetic mammogram. By doing so, we don't have to have another mammographic scan, because doctors are still very familiar with the mammogram. So in the early stage of DBT, they wanted to see both DBT and mammographic image as well. But now commercial vendors also provide a synthetic mammogram to remove the necessity of taking another mammogram that's going to be burdensome in terms of radiation dose. So typically, how do we get the synthetic mammogram? We can think of soft tissue enhanced one by use of forward projection of the reconstructed image, and also high density or high spatial resolution enhanced image like microcalcifications by use of maximum intensity projection. So typically they use a forward projection plus maximum intensity projection to come up with this kind of synthetic mammogram. Again, this is acquired from the reconstructed DBT volume image. Okay, but because we know that we have a BPF algorithm that is strong against the ripple artifacts and undershoot, so we wanted to utilize that, and we realized that if you have additional iterative algorithm following the BPF algorithm, and EM stands for expectation maximization algorithm, which is widely used for tomographic image reconstruction. And a few times of EM iterations, it provides a much higher image contrast, even though it fails to reduce the undershoot artifacts or ripples. So we both utilize these two images as an input, and then finally we wanted to have a synthetic mammogram that is free of ripple artifacts, undershoot artifacts, but at the same time preserving high contrast and resolution. So this one shows an example of a central projection, the real projection image from a scanner, and this is a synthetic forward projection of the reconstructed image using BPF and EM algorithm. You can see, although it's a little blurred, but compared to the central projection, the contrast is quite well restored. And also we added a little bit of more image processing tools to enhance the sharpness of these structures. I'm not going to talk about the details, but we use the linear structure weighted scheme, which is using a kind of oriented beam operators with different ranks. All right, so here, this is the forward projection that we have acquired from the physical phantom case. On the right-hand side, this is the maximum intensity projection of the phantom, and then we combine them. So this is the zoom-in image of the region of interest in the phantom. The part A shows the real digital mammogram images. Okay, the contrast patterns and circle and microcalcification simulating structures. And see, for example, DEF edge-weighted technique, forward projection only, and maximum intensity projection only. Those are all inferior to this mammography. And C here is the so-called central view augmented method, which is a method that is used in commercial vendors. Okay, and B is what we have produced by use of our proposed technique. The contrast has been well restored, and also microcalcifications are all well restored to a very small size. And particularly these fiber-like structures are, to me at least, it's more kind of a perceptible. I mean, it's more kind of clearer than the central view augmented method. And we apply this to the clinical data set. Here again, A represents the real mammographic image, and B is our result, and C is the central view augmented, and D, E, F are the techniques under comparison. All right, so we have successfully developed the synthetic mammogram technique, and part 3 and part 4 are kind of applications of deep learning techniques. In many cases, we need breast thickness information. Immediate application of breast thickness information is that, you know, because the breast shape is non-uniform, even after you have a compressed pedal, particularly in the periphery region, right? So in a single projection image or mammographic image, the intensity would be varying across the field of view. But doctors definitely want to see in a kind of a normalized scheme so that they can see all the structures within the breast. So what people usually do is they apply a thickness correction. For the thinner part, they apply a overweighting, a thicker part, you know, less weighting, something like that. But it's very empirical. And also for other applications of thickness information, if you have, would be some quantitative imaging like material decomposition and so on. What we have tried is using a conventional, people are using a lot of, convolutional neural network these days. And we also applied a representative network called UNet. And then we provided 2 inputs. One of the input is the projection image. And also you can calculate the Euclidean distance map from the edge of the breast. That can help the network to localize where we are looking at from the overall breast kind of anatomy, so that they can better, the network can better estimate the thickness. And since we do have a ground truth, we train this network so that we can get the thickness corrected projection data. And we use the numerical phantom provided by FDA, which is called the Victor package. It's kind of realistic, and you can create a number of different types of breast in terms of size and the density and so on, fatty breast, dense breast, and so on. And also they also provide a Monte Carlo GPU-based projection simulator. Combining these 2 tools, Victor and MC GPU, you can get more like realistic projection data in simulation environment. And then this is the input projection data we give to the network. And this is the Euclidean distance map that we also provide to the network. Again, from the boundary of the breast, you can calculate the Euclidean distance, in this 2D map. And D is the output that you want to have, which is thickness corrected projection data. And C is going to be the thickness map. Okay. So since in a Victor Phantom, we do have all the informations, you can train the network. And this is the normalized projection, Euclidean. This is thickness corrected image. The network was trained very well, and we didn't see any problems like overcorrection or something like that. So so here shows you the example images applied to the testing cases. A, ground truth, B, the output of the network. So you can see pretty close, image each other. And C shows you the difference between them. It's a negligible difference. Line profile also confirms that. Another case in a more like a fatty breast, a little bit of artifacts. Sorry, the anomalies are shown, but it's negligible. So we came up with this thickness estimation network successfully. When we applied this, by the way, for image reconstruction in DBT, although I'm not showing you the DBT reconstruction here due to the short time, but also we applied this thickness information for material decomposition in the following. So what we wanted to do in this project was, can we get the material decomposed images from DBT scan? Of course, then you have to have dual energy imaging, right? So at the same dose condition, I mean, at the neutral dose condition, you don't want to put more dose to acquire high and low energy information. So what we have proposed is, in a conventional scanning mode, we simply wanted to change the tube voltage, once high and the neighboring one low, high and low, high and low. Okay, so in this interlacing scanning mode, you can get pretty much the same dose to the conventional DBT. And then we wanted to, what we wanted to do is we wanted to synthesize all high projection data and all low energy projection data from the acquired projections. So we basically gave this input image from all the different view angles as a single input package. And then we wanted to get the, for example, this one, as you can see, purple and blue represent high energy and low energy projection data. And in this case, for example, we wanted to get a high energy projection entirely, and vice versa. Another network you can train to produce a low energy projection data, right? So you can get high energy projection, low energy projection, at the same number of projections that we usually use in a conventional DBT system. So we wanted to test the performance of material decomposition of having this high and low energy projection data. Again, we used the pork phantom with certain ingredients, some other species to represent some other types of materials. And this is the ground truth high energy projection, low energy projection. This is the synthesized high energy projection by use of the network. And this is a synthesized low energy projection data. The difference between the ground truth and synthesized ones are shown over here, very minimal difference. And we also implemented another network for comparison, which I do not want to describe here, but obviously that does not give us successful synthesizing projection data. And then this is the result. On the left panel, this is the ground truth of image at the low energy projection, high energy projection, and after material decomposition, you can get water-based image, protein-based image, and lipid-based image. And the middle column shows you the results of our network. Again, this low energy is produced by use of the network. It's a synthesized low energy image and synthesized high energy image. And after decomposition, it looks pretty similar to the ground truth. However, another network that we have implemented for comparison resulted in visually, it looks pretty similar to low energy and high energy wise, but after material decomposition, they kind of largely fail, okay? And you might ask me, we have dual energy projection data, which means we have two equations, but how can we get three component images? Like we have three unknowns, right? You're right. So to have three component decomposition, you have to have an additional constraint. And that is exactly the breast thickness information. So we utilize low energy projection, high energy projection, and also breast thickness information using these three information as three equations. It's kind of a system of linear equations, then we can solve the components that we want to visualize. Okay. I think I have a little more time, right? I started like 3:40, so I'm gonna complete my presentation. So I just wanted to briefly introduce you the power of combining optical imaging in breast imaging. Okay, these are the list of papers that we have published on this DOT imaging. So obviously optical means we are using a kind of visible light or infrared light for imaging. Obviously, they have a very short penetration length, but interestingly, the if you select the wavelength very carefully, there is a so-called kind of biological window here, where absorption of water or hemoglobin, oxygenated hemoglobin, those absorption is quite low, although the scattering is quite kind of stay constant there. So we choose appropriate wavelength, then we might have a chance to see the image contrast between water and this hemoglobin. Okay. So in collaboration with other institutions in Korea, we have developed a hardware that can provide us DOT scanned information. We use this kind of three wavelength light sources, and also we used avalanche photodiode based detecting system with 40 channels. So here I'm showing you the results. So this is the case of a patient having cancer on the left breast. So in DBT, probably radiologists can point out that this is the suspicious lesion. On the right breast, there is no cancer. And DOT scan actually provides you kind of hotspot that is, likely to be related to hemoglobin concentration. I mean, usually the cancer needs a lot of nutrition, therefore they have an angiogenesis, they have a blood structure systems, they recruit, and usually the hemoglobin concentration is high compared to the normal background. So we can see those kind of spots there. In the middle, we are not using DBT mask. And on the right, it's talking about the image reconstruction of DOT. Since we do have a DBT image, we wanted to use as a kind of guide for DOT image reconstruction. And actually, it turns out to help the image reconstruction. So please focus on the right panel. All right. And again, another patient having cancer on the right breast. Again, we have a good correlation between the cancerous case or non-cancerous case. And healthy patient, we have no hotspots here. And also benign cancer appears to be cancerous. I mean, appears to be a lesion in the DBT scan, but turns out those are benign, having no hotspots in DOT. And these are the images of those previous examples, fused together on top of DBT. We put these DOT images. So surprisingly, from our retrospective study, the sensitivity was increased to 100%, and specificity was increased to 93%. Although it's a controlled retrospective study, but we believe it's very promising imaging technique for breast cancer screening or diagnosis. All right, these are the students who have worked on this project. So that's it. Thank you very much for your listening, and I'm more than happy to answer your questions.
Thank you, Professor Cho. for a very useful and informative informations between different algorithms of DBT, as well as how the synthetic mammogram has been produced, as well as all the interesting things, the breast thickness and DBT. So
Thank you.
I think you said that you will leave after that your lectures.
Right, I'm
So
sorry,
if-
unfortunately.
Yeah, that's okay. So if I do not find any question till now, so if we have any questions, then I think the organizer will send you through your email,
Oh, yeah.
and then you can send your questions query to the organizer, and they will put it. I think so.
Thank you. Sure, I will
Okay.
do that. Okay.
Okay. Okay. Thank you,
Sure.
Professor Cho.
Okay, thank you very much.
Thank you.
Thank you.
Now the second speaker, the engineer Kathrin Entz. She will speak on imaging of pregnant women. And this is a very interesting topic. I think so that every people should know these things. And I will request engineer Kathrin Entz to have your speech. Thank you.
Thank you very much for the introduction. And of course, thank you very much for having me here today. I'm just going to put it to laser pointers. So hello from my part. It's here, good morning, but for you probably not. So my topic is not as scientific as the one before. It's more in a practical way, but I think it's a very important topic because it's a very sensitive one. I'm going to talk about imaging of pregnant women, and I divided it into 3 parts. First, I want to talk about the possible effects on the unborn child. Then I show you how you can do dose calculations to find out what the effects exactly are for the child. And then in the end, I want to show you just very briefly what a good workflow could be when you're imaging pregnant patients. So normally you don't see it very often that you have to image pregnant patients. Usually that's totally avoided. But of course you cannot avoid it all the time because some patients just have to be imaged during the pregnancy. If a woman has a traumatic accident, for example, then it's absolutely necessary to get a proper diagnosis. Then again, we also have those patients who are not aware of the pregnancy when they are examined. That might be, for example, in the very early stages of the pregnancy. And when the women are examined, then there's usually a lot of confusion about the risks, not only among the patients, but also when we're talking about medical personnel. So radiologists or radiographers, they usually don't know what the exact risks are when you're imaging a pregnant patient. There's everything from there's absolutely no risk to you cannot do this at all. And to conquer this a little bit, I'm going to show you what really could happen and what you should do when you're imaging pregnant patients. So whenever we're doing imaging and with ionizing radiation, we do have some health effects that we do not actually want. We can divide it into 2 groups, the stochastic effects and the deterministic effects. The stochastic effects, they describe a statistical chance that you see those effects. The probability increases with dose. So the higher the dose, the more likely it is that these effects will occur. And they do not have a threshold dose. So even very low doses might cause these effects. And when I'm talking about effects, I'm talking usually about cancer, so leukemia or solid tumors, and we also have genetic effects that fall into this category. On the other hand, you have these deterministic effects. They only occur above a certain dose threshold. So that's really good for us. So as long as we stay below this dose thresholds, then they do not occur. But the higher the dose, the more severe those effects are. And certain deterministic effects are, for example, lens opacities. And if the doses are very high, they can lead to cataracts. And what's also quite common are all effects to the skin. Start with an erythema, so just mild reddening of the skin, and that could develop into a necrosis when the doses are very high. Of course, there are also other effects, but they're usually not so easy to link to the radiation. These are the effects that you always see when you're imaging any kind of patients. And when we're talking now about pregnant patients, we also have to consider additional effects for the unborn child. And when we're talking about an unborn child, you have to keep in mind that it develops throughout the pregnancy. So it first starts with the pre-implantation phase. That's usually 2 weeks post-conceptus. Then after that, we have the organ developing phase. That's usually divided into 2 parts, an early stage and a later stage. So between 2 and 15 weeks, we have that. And then after that, we have the fetal growth phase. And depending on the phase you're in during the irradiation, the effects are different. So let's first have a look at the pre-implantation phase. Like I said, it's usually roughly the first 2 weeks post-conceptus. If a woman is irradiated or had some imaging during that phase, then we have the risk of embryo loss, but not of malformations. And this is called the all or none phenomenon, or all or nothing principle, or something like that, because at that stage, we're not really talking about an actual child. It's more like a handful of cells. And that means if one of those cells is damaged, then the effects would be really severe. And that's why the pregnancy is automatically terminated at that stage. And that's why you have the risk of embryo loss. But as long as no cells are damaged, then you won't see any effects. And that's why you have no malformations. And that's why it's either you have the embryo loss or you have no consequences. And that's why this is the all or none phenomenon. It's a deterministic effect. So you have a dose threshold, which is quite high for diagnostic imaging. And this is actually one of those cases where the woman is usually not aware of her pregnancy because it's so early in the pregnancy, she usually does not know that she's pregnant at that stage. So usually women get their CT scan, for example, and then later on they find out that they're pregnant, and then they come back to the hospital or the imaging center and say, oh, I just noticed I'm pregnant and I just had a CT scan, so what is going to happen to my child? And that's really good for us because we can say if there was no embryo loss, then nothing happened and everything is fine. In the later stages, it's not like that. So in the organogenesis, it's the organ building phase. This is the phase where the organs are developing. So that means the organs are very sensitive to radiation. And that's why we also have the risk of malformations to the organs in this stage. So we have here a risk of neuropathology or growth retardation, but fortunately also at quite high dose thresholds. In the later stage, you do not only have the risk of malformations, but also of an IQ reduction. But as I will show you later on, it's not a high IQ reduction. It's hard to see at all. Then we have the fetal growth phase. It's already a bit later in the pregnancy, and that's where the child is already more robust. You still have the risk for malformations and IQ reduction, but at a quite high dose threshold, so above 500 milligrams. That's hard to reach when we're just talking about diagnostic imaging. And then in the very late stage in the pregnancy, after 27 weeks, there were actually no detectable effects. So here I have a summary of all these different effects and the different stages of the pregnancy. It's from a different publication, so the values might differ slightly, but altogether they're pretty much the same. You have here the different stages and the time post-conceptus. And then what's really nice from this publication, I like that they divided it into 3 different groups. So you have a low dose group here then medium range dose values and the very high dose values. And you can see that when you stay at low dose values, there are no deterministic effects. In the medium range, there are no malformations and maybe just slight IQ reductions. And only if you have really high dose values, you can actually see malformations or other deterministic effects. And then what I have here in the last column, it shows you the risk coefficient. So for example, if we look here at the IQ reduction, you can see it's very low. So it's not really something that you can see on an individual person. So from looking at the table, you could say, okay, nothing is really going to happen when we're just talking about deterministic effects. But of course, we also have the statistical effects like the cancer induction. And that's actually the reason why we should avoid imaging pregnant women, because not because there might be the risk of malformations, but more likely because we could induce cancer, and unborn children or young children are very sensitive to radiation. So the risk of inducing cancer in those is pretty high compared with adults. So because you have this risk, it's better to avoid any unnecessary imaging during pregnancy. Genetic effects are also most of the time listed, although nothing has ever been seen in humans, like any damage to the reproductive system, but they have seen in animal studies. So just if you want to list them, you have here the risk coefficients. And other genetic effects might also be infertility, but that's more like a deterministic effect that you only see at higher dose values. So if we're trying to avoid examinations and any diagnostic imaging during pregnancy, of course, there are examinations that we have to carry out. And here you can see in what cases you actually would have to do any examinations. Like typical radiographs or just general x-rays, you would do them, for example, after traumatic injuries, as I said earlier, like car accident. Then you would check for fractures or luxations. If a woman has trouble breathing, you would take an x-ray of the chest to check for pneumonia or pneumothorax. CT, which is even with a higher dose, is even more rare to see during the pregnancy. You would, of course, do that again when you have a trauma. Then you would check for fractures or internal bleedings. Chest CT is also quite common because pulmonary embolism is the #1 cause of death during pregnancy for women. So you would have that, of course, and a CT scan of the head, for example, to check for aneurysms. So all these are cases where you would have to take imaging and to use radiation during the pregnancy. You cannot avoid it. And that's why it's important for us as medical physicists to understand how you can calculate now the effect for the unborn child. You can simply do it in 3 stages. You would start with the pre-implantation phase. So you could check, is a woman in the very early stage of her pregnancy, because there you have this all or nothing phenomenon. So it's very you either have effects or you don't. If you're later on in the pregnancy, you would start with a dose estimation. So just rough values are enough. There you would check, are you in a low dose range or in a high dose range? And as long as you stay in a low dose range, you wouldn't have to worry, because as you've seen earlier, in the low dose range, you don't have any deterministic effects, and the risk of inducing cancer is very low, so you can neglect it in this case. And only if you have really high values, you would check again with actual dose calculations, and there you would really determine what could possibly happen to the child. Or in a more detailed version, you can see it here. You would start by determining the time post-conceptus, and if you're below 10 days or a maximum of 14 days, you can say, okay, you don't have to do anything further because the all or nothing principle. Then if you're past those 10 days, you would start with a dose estimation. If you're staying in a very low dose range, so below 20 millisievert, again, you wouldn't have to do anything because the dose is so low that you won't see any deterministic effects, and the statistical or stochastical effects are negligible. And only if you're in a higher range, you would start with those calculations. So start with more detailed values. And again, here you would separate it into two groups. If you're in the medium dose range, again, you wouldn't have to do anything further. And only if you're in a very high range, you would talk about maybe possibly terminating the pregnancy. So how do you do now with dose estimation? It's actually quite easy for radiography and fluoroscopy. There are certain tables you can just use, for example, like this one. Just 1 second, I think I made some mark there. I cannot erase this, so my apologies for that. I hope you can still see everything. So here you have this table where you can see the different types of imaging, and for different views, for example, AP view or PA view, and different patient sizes, like a small patient, medium, and large patient. And you would simply take whatever was appropriate for that examination. For example, if you have a radiograph, you would look here in this line, take, for example, an AP view with a medium patient, and then you would have 3 millisievert dose to the uterus for that radiograph. This table here gives you values that are very conservative, so are actually more likely going to overestimate the dose to the uterus and therefore the dose to the child. So that's actually good for an estimation, to overestimate it just to be on the sure side. And also for that reason, we only consider images where the uterus is directly irradiated. So everything that's far away from the uterus. So if you take in, for example, an image of the hand, we don't use the dose of those to estimate the dose to the uterus. For the CT scan, it's also not very difficult to estimate the dose. You would do it according to this formula. That means that you have the CTDI wall, so a value that you can simply get from your CT scanner, and you would use a conversion factor and multiply them. And it's actually quite easy because you only have 3 conversion factors depending on whether the uterus is in the scan range or not. If it's completely in the scan range or partly in the scan range, you have the high conversion factor. If it's adjacent, then you have a much lower conversion factor. And if it's far away from the scan range, you have a very low conversion factor. So you can see that it's quite simple to estimate the dose. But one thing you have to keep in mind is where the child is, where the position of the child is. Because during the pregnancy, of course, the child is growing, and to determine whether it's inside the scan range or adjacent to it, it's always good to keep in mind where it is during the pregnancy. So it starts in the beginning very low in the pelvis, and then in the end of the pregnancy, it's going more upwards. So for example, a scan of the chest. In the beginning, it's not very crucial, but in the end of the pregnancy, it's very close to the child. So I have here an example case for you so that you can follow with all the dose estimations. we had a pedestrian. She was 6 months along and she was hit by a car. So normally we would do a CT scan of the head and cervical spine. That was done. And then normally we would also do a CT scan of the rest of the body, of the trunk. But because she was pregnant, the doctors modified our normal trauma protocol. And instead of taking a CT scan, we only did an X-ray of the chest and the pelvis to lower the dose to the child. So what we would now do is, okay, here first you can see it. Maybe here is a little bit of the head. It's hard to see. I also have here the MRI image that was taken a little bit later on. Here you can see the child and the position of it. So for the dose estimation, we start with the CT scan. We did a scan of the head and the cervical spine. It was done in one scan, and you would take here your simple formula, take the CTDI value. You know that it's far away from the scan range because it's head and neck. And so you have here your conversion factor, you have your CTDI value, and you just insert it into the formula and you get obviously a very low dose to the uterus. So because of the CT scan, because the CT scan was so far away from the actual uterus, there won't be a lot of contribution to the uterus dose. Then we also did radiographs. We had two, one of the chest and one of the pelvis. So for the chest, the uterus was not exposed. That means we don't have to consider it now for our dose estimation. We can ignore it. But obviously the pelvis region is where the child is. So we would look here into our table. We have a radiograph. The patient was already large. So simply we can take the 5 millisievert as an estimate of the dose to the uterus. So altogether we have the dose from the CT scan and from the X-ray. So altogether it's 5 millisievert approximately. And if we go here through our flow chart, we say, okay, it was more than 10 days, it was 6 months. So we did the dose estimation and we stayed well below 20 millisievert. There's nothing more to do for us besides obviously documenting those values and informing the patient. But then again, we could have situations where the dose is higher and where we would have to do dose calculations. For radiography and fluoroscopy, you would have 3 different methods. You could either do it with conversion factors by taking your air camera or your DAP and multiply those values with certain conversion factors that depend, for example, on the size of your image and the distance from your scanner to the uterus. But you could also do it with a ratio tissue air. Again, you would take your air camera or your entrance air camera. Also in this formula, you would have the size or the fields that you're irradiating. You would also take into consideration where the uterus is and different other factors, or you could use depth stairs tables. In the former report, this is also again from the GGMP report, there were for the CT really detailed calculations where you would have to take specific parameters from your specific CT scanner. But in the most recent report, they changed it simply to more detailed conversion factors, which is actually really nice for us because it's much simpler. So instead of the 3 conversion factors we saw earlier, you now have for different scan region, different conversion factors. And again, you would simply multiply that with your CTDI value. One thing you always have to keep in mind when you are working with the CTDI is that it's not describing the scanner output, that is just describing the scanner output and not the patient dose. So if you have the same CTDI value, but one patient is very small and one is very big, the effects obviously wouldn't be the same for those two patients. And that's why the SSDE, the size-specific dose estimate, was introduced. And that corrects for patient size. And that is one thing you could also do when you are calculating the dose to the uterus, to use those correction factors to correct for the patient size. So if you have a very small patient, you could use those correction factors. And if you have a large patient, you could use the very factors here at the very bottom. In this table, you have the effective diameter, which is easy to calculate from the dimensions of the patients, which you can simply measure from the images. But obviously, you could also use a water equivalent diameter. That's also possible, but usually it's more difficult to acquire those values. So I'm just giving here the effective diameter and the correction factor for the effective diameter. So another case for, as an example for the dose estimation here, we have a 38-year-old patient. She said she was approximately 6 to 8 weeks pregnant. Later on from the images, it was determined that it was more likely 12 weeks, but it's not important for our dose calculations or dose estimations, because we know 6 weeks or 12 weeks, in both cases, we would start with a dose estimation. She had 3 different CT scans, one of the chest to check for pulmonary embolism, then a CT scan of the complete trunk, so chest, abdomen, pelvis, which is our normal trauma scan to check for internal bleedings or fractures. And because it wasn't totally clear from the second scan, we had to do another CT scan of the abdomen to check for internal bleedings. Because we did the dose estimation earlier, I'm not going into the details. You can see here all the values for the different scans, the required conversion factors, and then what you would get when you multiply those values, the different dose estimations. So altogether, from our estimation, we would get a dose to the uterus of approximately 50 millisievert, so which is quite high, far away from this limit of 20 millisievert, where we wouldn't have to do anything further. So this means for us now that after the dose estimation, we would have to do a dose calculation. So, like I said, we just need other conversion factors. They are more detailed now. And again, because it's simply multiplied, I'm not showing you here the different calculations, but altogether we get here those values. We can now correct for the size. So you could use this formula here to correct or find the correct correction factor for the size. In this case, we look at the images. You can see actually that it's a very wide patient. She's even wider than our field of view of the scanner. And here in the AP dimension, it's about 24 centimeters, which inserted into those formula would lead to a correction factor of 1.01. Just multiply it, and then you would get from this value to this. So it's not a big difference because it's approximately 1, but in this case, it's a little bit higher. So from this, you would say, okay, she is still way below the second limit that we have, way below this 100 millisievert. So again, we wouldn't have to do anything further. We could rule out any malformations, IQ reductions and things like this. But of course, in this case, there would be a slight risk of cancer induction. But again, in this case, it's still very low, but of course, it's not 0. For the dose calculations, you could do it the way I showed you, but you can of course use all kind of software that you might have. I'm very lucky because at our hospital we do have a dose management system. You can see here what it's doing when we have a pregnant patient. We can use different phantoms that show different stages of pregnancy. So in this case, I have one that is 9 months pregnant, and you would see the dose values here on the right side. But of course, you can also use any other tool that you can find, like CT Expo Impact, or also any open source program that you might have. I would not recommend to rely on those software tools completely. The way I do it usually is that I calculate all the dose values myself and then compare it to any software so that I have a good idea whether my values are correct or whether the software values are correct, just to be sure, because like I said in the beginning, it's a very sensitive topic. So like I use the software more as a plausibility check, but if you don't have a software, here is another table that helps you to check for plausibility. So if you have calculated the dose values and you're not sure if you're correct or not, you can look at these tables. So these are typical dose values that show the uterus dose from different examinations. So you can see radiography of the head, chest, or extremities lead to very low doses to the uterus. And if you have, on the other hand, a CT scan of the trunk or of the abdomen and chest, it's very high. So whatever values you get from your calculations, compare it usually, or compare it here with values from this table, so that you know whether your calculations were correct or not, because the effects are quite severe if you have wrong calculations. So in the end, I'm just going to show you a little example workflow of what you should do. Before you start the examination, you should always determine the pregnancy status, which means at our hospital simply that we are asking the patient if she's pregnant or not. I know that there are other hospitals that are actually doing pregnancy tests just to be sure, but I think that's way too much. Whatever you're doing, it's important to document the results, because I've also seen pregnant patients or patients who claim later on that we ignored what they said, and we imaged them in spite of their pregnancy. Then if you know you have a pregnant patient, you should always do the justification, or the radiologist should do the justification. Of course, you have to do that for every patient, not only for a pregnant patient, but when you have a pregnant patient, it's even more important to look at the specific aspects that come along with the pregnancy. So the radiologist should see or determine, is the examination really necessary? Could we maybe use other modalities like an MRI scan or ultrasound that do not use ionizing radiation? Maybe is it possible just to postpone the examination? If it's not an emergency examination, of course, then maybe we can do it later on in the pregnancy, because at that later stages, the child is more robust and not so sensitive to the radiation, and not so sensitive for malformations, for example. If the examination is necessary, then of course we should talk to the patient, explain the risks, explain them in a proper way that the patient can actually understand everything. It's really good to use proper wording, not to worry the patient too much, but to make sure that they really understand what is going on and what might be the risks. And of course, if the medical physicist hasn't been involved so far, then they should be informed so that they can help to adjust the examination later on, because that would be the next stage. If you're doing the examination, adapt the examination parameters, try to lower the dose if it's possible. Don't do it on your own if you're the medical physicist. Always talk to the radiologist. So as a team, discuss what is possible. Could you lower the dose? For example, could you decrease the number of scans? Could you swap, like we did in the one example, a CT scan for radiographs? Do anything to lower the dose for the patient and therefore for the child. For years, it was recommended to use like lead aprons or other things for scattered radiation. But nowadays, in most countries, it's not advised to use them anymore. It's always a bit difficult. If they're not in the scanning range, then of course you can do it. They usually just for psychological reasons. Because most of the time radiation is also scattered inside the body, so they are not really helpful. But as I said, for psychological reasons, they are usually very helpful. You might do dose measurements, but in most cases, they're also not really working because you have the scattered radiation inside the body. So whatever you're doing to measure the dose, you won't get the actual values of the child because you're measuring outside the body. So this is most of the time not working. Sometimes you can do something, but most of the time it's not working. So more important it is to evaluate the dose after the examination. You start with the estimation and then continue with the calculation of the dose. And then depending on the value of your dose evaluation, you analyze the risk and then, of course, inform the radiologist, discuss the results, what that will mean to the patient. And in the end, the results should be explained to the patient. The good thing for us is in most cases with diagnostic imaging, we have very low dose values, so we don't have to worry. But of course, we have to explain it to the patient properly so that they can make informed decisions. And what is also a very good idea is to have like something like this. It's a checklist where we have everything step by step, so that even young doctors, young radiographers who have not much experience know what to do, because these cases are also seen like during the night, on the weekends, when there's not much personnel, when there are only the inexperienced people. So you can use this formula here and go just step by step. And so everyone knows what to do. So to summarize everything up, of course, ionizing radiation can harm the unborn child, but fortunately the doses in diagnostic radiology are very low. So in most cases, we won't see any malformations, any growth retardations or anything along that way. So no deterministic effects. But of course, we do have the stochastic effects, so we might induce cancer. And for that reason, we should try to avoid imaging pregnant patients. But of course, it's not always possible. And for those cases where we have to image pregnant patients, it's advisable to establish a certain workflow so that everyone knows what to do and how. For example, also to talk to a patient. In our checklist, we also have certain wordings for the radiologist so that they know what to do and how to explain the risk to our patients. I have here some additional literature for you. The ICRP has some publications on imaging pregnant patients. I think they're now in the stage of revising those publications because they're already a bit dated. But here, for example, from the American Society here, you can find a more recent document. It was RISE 2023, so this year, and there you can find more information on imaging pregnant patients. And with that, I thank you for your attention, and if you have questions, I'm glad to answer those.
Thank you, Diploma Engineer Kathrin Entz. And this is a very, very informative lectures. And I think you showed very clearly with very, very good examples how we can deduce and dose estimate to the pregnant patients. So we'll come the question answers in the last, after the end of the last speech. So now I will invite Professor Golam Jakaria to talk on quality assurance program for diagnostic computed tomography. So please, Dr. Zakaria, that's your speech.
So good morning, everyone. Thank you, Professor Azhari and the team to invite me to talk in this audience. I have seen 84 participants there. I think most of them are medical physicists, and computer tomography is actually very important, not for the diagnostic and therapy, but it is a branch where the medical physicist is increasing responsibilities. You know, in 2019, I think it is January, in Europe, there is an ordinance that in computer tomography and interventional radiology, the medical physicist should be appointed. That means you should have a medical physicist in your department when you have computer tomography or interventional radiology. And even in the practice, you cannot start a computer tomography diagnostic so long you have a contract with medical physicist. This is good for our profession, and of course it is good for the patient as well, because medical physicists know the quality insurance and of course the dose problematic. And this is our challenge, to have a good quality with less dose, what we are doing in the department. Here is my topic, is quality assurance program for diagnostic computer tomography. I have prepared these slides based on the IAEA Human Health Series 19. There is a publication, I think everybody of you know, when somebody is known to this publication, you can read it very well, because it is a very, very good guideline to establish quality control for computer tomography in your department. This work is also very nice because it is not only for diagnostic, it is to establish a quality assurance program for radiotherapy. So this is actually a very comprehensive topic. I have taken some subject from here. You see the first of introduction and then CT technology, and then I can say something about performance requirements in CT, and of course the basic principle of quality assurance in CT, and give some outline of performance test, and then radiographer test and medical physics test, and last I will give you some photos of phantoms and equipment. And there you can see we have some also equipments for quality control in radio diagnostic. it is not extensive, just like a radiotherapy, but still we need the phantoms and equipment. This is a machine everybody knows, this computer tomography machine. And this machine is actually all-rounder in a department. When you, even after the when the department is closed, but you can see every time the computer tomography machine is there. Yeah, you do not know when some patient or some accident patient is there. So every time it is a urgent possibility to a computer machine in the department. Here I have given some points for introduction. CT scanner provided high contrast cross-sectional images. You know this, making this essential for soft tissue diagnostic in contrast to normal radiology, yeah, in soft tissue diagnosis. It is actually, compared to other techniques, I can say here, in other diagnostic techniques, the patient radiation dose might be much higher. Yes, this is actually another concern, especially for the pregnant and young patient. Kathrin had give very nice lectures where she described very elaborately in this case of newborn and pregnant woman, how can you calculate and what is actually the whole problematic. And this is actually, I told you, the high dose are frequently caused by inadequate radiotherapy techniques and equipment difficulties, because that's why the education and training of radiographers and radiologists is very, very important, because without clear education and training, there can be some mistakes and equipment difficulties. This is our domain. That means the medical physicist should be very sensitive to know the machine has its clear without any equipment difficulties. This is what I am to say. The scanner are constantly developing, necessitating continued professional education for optimal operation. Yes, the machine is always new machine and new procedures, and this should be known to these three categories of people: medical physicists, radiographers, and radiologists. And so the further points, that means the quality assurance program is essential. And this includes, of course, I told you, the training and equipment maintenance through the biomedical engineer of the vendors and suitable protocols. Yeah, it is also advancing the protocols, and everybody, especially the radiographers and radiologists, should know which protocol is optimal for this examination. And of course, last but not least, the viewing conditions. Yeah, there is special viewing conditions and special display which should be applied here, and this should be also under quality control. Collaboration, I told you, yeah, the medical physicists, radiologists, and radiographers for optimization and quality assurance. Optimization is the main topic, and optimization is more important terms in radiodiagnostic. Here, we should always optimize so that minimal dose and best diagnostic photos. I told you this is actually, the CT is actually is the most important tools in the radiotherapy, in treatment planning. Without CT, there is no treatment planning. Yeah, in earlier time, the medical doctors had some radiology photos, and they do some two-dimensional treatment. So we cannot save the organ of Riggs, and this is actually not correct planning. And since the invention of cities, the medical physics can do a very exact plan where millimeter exact you can apply the dose, because you have a three-dimensional cities images, and it gives you in all dimensional the possibilities to do this. And this is the CT technology. I do not go to in details. Everybody knows there is a X-ray tube, and of course the other side is detectors. They are coupled with each other, so they are rotating, and you have some intensity profile, and from there we can have the attenuation profile. When the attenuation profile with some technology, with some calculation method, reconstruction method, we have our CT images. Here, once again, CT is a radiographic process that produces a photon attenuation map of the patient. To create a single image slice in the axial direction, the beam is constrained to form a thin fan across the body. Collimation is very important, and this collimation should be checked always, so there is not overdoses or you have some field which is not what you want. So the collimation should be very well. It is one of the tasks of the medical physics to have a right collimation. And this rotation of X-ray tube around the patient generates hundreds of attenuation coefficient. And through this all attenuation profiles, you can construct the image. Here on the right side, you see how the city's image looks like. And here's once again, I have given the title here, CT gantry tube collimation filters and detectors. You see here, CT tube operates between 80 kV and 140 kV according to the examination things of the pelvis or in breast or some other places of the body. You see here is a huge number of photons is produced. It requires efficient cooling and control ambient temperatures. This is also very important. Filter remove low energy photons, and specialized filters compensate for attenuation in different body parts. This also possible here. Here you see the internal life of a city. Here is a huge electronics and different parts. The biomedical engineer, they're coming in the department, and the maintenance, the quality control of this machine. Here's once again the slice width collimation I told you earlier determines beam width. A modern scanner can acquire multiple slices, approximately 320 of them. Detectors use high pressure xenon and scintillation materials, providing high dynamic range and low afterglow. A single slice scanners detectors from an arc, while multi-detectors cities have additional rows reducing motion artifacts. You see here the right side, the frontal view and lateral view. On the lateral view, you see a very pencil beam, and it gives a slice in the body. Image reconstruction, it is a very, very important. Professor Cho and has also given in the lecture, the image reconstruction is a very, very important tools. You have the profiles. I mean, out of profiles, you should have the image construction. Here, for the spiral CT is something difficult, and they construct also in 180 rotation or some small variation. And this is what's important in this image reconstruction. Every medical physicist knows the filter back projection is the primary method of reconstruction, but now it is increasing the irritative methods in the popularity. So in the new generation of cities, you can find also irritation method. And I have also read and seen the artificial intelligence you can also apply to have a exact photos of the cities. Here, CT scanning procedures, everybody know how it's come. First of all, the scan projection radiograph is a common initial image acquisition method taken without tube and detectors rotation. Yeah? Every time you see a scan projection radiograph, and here you can actually mark in which areas you should have the CTs. Axial image scans involve acquiring profiles around a stationary patient, allowing rapid reconstruction. Helical scanning combine coach movement with profile acquisition, reducing respiratory motion artifacts and scan time. And helical CT reconstruction is more complex, involving interpolation of aligned profile in a pseudoplanar state. And multi-detector CT uses set filtering, this is one of the terms, and offers flexibility in adjusting slice width, increasing data storage requirements. So here, optimization, as I told you, is actually the main business of medical physicists in a radio diagnostic department, especially in CT. Medical radiology exposure must adhere to justification of optimization principle. This is actually a justification for medical doctors, whether CT is in this case is needed or not. When not needed, you advise the patient go to the other modalities like ultrasound or MRT. The increasing number of CT scan raises concern about the radiation exposure and potential cancer risks, particularly in pediatric patients. Yes, it is a high doses because we do many slides in the body. Optimization medical radiology aims to minimize patient exposure, where maintaining image quality, clinical needs, and involving radiologists, radiographers, and medical physics. The three profession people should work together here. Teamwork is very important. And here is the work of medical physicists to inform the radiologists and radiographers all the protocols and what is here possible to minimize, optimize. This is that's why continuous training and continuous work with the radiographers and radiologists and medical physicists. The medical physicists should always with them, and there should be a very good relation so that they feel also to have a funny for this work. The European Commission has developed quality, naturally and other also, but European Commission quality criteria for good practice in CT. This criteria established technical parameter for image quality in relation to patient dose, specifying diagnostic and dose requirements for various anatomical regions. In the Germany, we have also such types of quality control protocol and many papers, but in the German language. But actually, IAEA gives the possibilities all over the world to work. Here is the expert from all countries together to do a guidelines and protocols. So when you follow IAEA, you have actually have the physics and technology from all over the world. Here, optimization of clinical practice, factors affecting image quality and dose. The quality and dose, the two terms, radiographic protocol and scan parameter. Equipment, image reading condition, as told you earlier, and patient-related factors. Yeah, different types of patient, different areas, and different thickness, and all are considered intuitively. Performance requirements in CT. Here is another title. Here you see scan and patient position accuracy. This is actually very important. And you have many lasers. So when you just start radiochromography, you see internal lasers, external lasers, and these all lasers had their function. And of course, in quality control of the laser should be done frequently so that the laser have the right purposes for these purposes. Testing scanner quality involves ensuring the accuracy and reliability of these lights. Yeah, you see here I will not read all the parameters here, but lights are typically used as a guide for patient setup, centering, and avoiding unnecessary radiation exposure. Preparation of CT scanning is based on the scan projection radiograph to define the scanned volume. Accurate light positioning is crucial for diagnostic imaging, biopsy guidance, and protecting radiosensitive organ like the eye during brain scan. When you have a brain scan, some neurological examination, you shoot with the laser, you see the patient so that the eyes should be set, because eyes at a certain dose, when you do not maintain, then you have some cataract. So this is actually, this dose is earlier time, this dose is higher. Now, after the new biological physics, then we can, the dose is less. So it is a very sensitive for eyes when you have some neurological examination. Here we see image quality depends on the following factors. CT number. Every physicist knows what is the CT number, how can calculate the CT number, what is the relation with CT number with the dose. These are very important. And image noise, and of course the contrast to noise ratio, uniformity of image noise and CT number, image artifacts, spatial resolution, partial volume effect. These are all factors that determine the image quality. Here the dose, physicist is always with dose, but CT in dose is defined something different than the normal dosimetry. Here you see the term, you have learned the terms CT-DI, computer tomography dosage index. You understand what is this, and of course there are many terms associated with CT-DE, and from the CT-DE you can calculate the DLP, that means dose length product, and this is actually, CT-D is only one slice, and when you have the area of the body, you can calculate the DPL, and from the DPL you can calculate the effective dose. This effective dose, actually the dose, what should be determined, and there is many tables, and Kathrin has showed you how it calculates, and from the tables you can calculate it from the different bodies, and there is some factors, and these factors is also depends upon different parameters, and of course you have you can download also some program from the internet, and this is you, the physicist, should check such types of program before applying. You can calculate from the CTD, the DLP, and then of course the effective doses. Here, the understanding the concepts of CT dosimetry indices, dosimetry for CT scanner with large collimator beam weights, calculation of organ dose from CT scanner, dose calculation for CT scanner using some form of AEC. AEC is also actually a very tools. In earlier time, there is not AEC in the computer tomography. Therefore, we overexpose to the children. Now, every patient, according to the body, it is adjust the voltage and of course the current. Dose parameters and DICOM headers. These are all important, and it is actually now you saw dose management system. Many hospitals, especially the big hospital, they have dose management system, and I think it is actually very good tools for physicists. They managed everything, and when some discrepancies, some artifacts, they give in a warning. But for a small hospital or this is a small practice, when there's only one city, it is not easy to buy a dose management system. It costs sometimes 20 to 30,000 euro. Therefore, you should have a table. Yeah, it doses diagnostic reference value. Yeah, this is very, very important, and every medical physicist should maintain this diagnostic reference value. There is table for the adult and of course for the children, and every country should establish such a diagnostic reference levels. Even you can use the international values from the IAEA, but in Germany we have our own values, and it is your duty to maintain these diagnostic reference values. Basic performance of QA in city. This is what we are going to talk in these lectures. And you see here QA activities. A quality assurance program in diagnostic radiology ensures high quality diagnostic images while minimizing patient radiation exposure and cost. Yeah, the cost also a factor. Yeah, many people think when you have a physicist and you have some equipments for quality, it costs the hospital extra cost. But in the long run, when you have a physicist and the equipment, you have less cost. The hospital, you save money in the hospital. This should be explained by the administration how and be. It is also the duty of medical physicists. This is actually a process which save the cost and the patient dose. QA program for medical exposure should encompass various elements, including measurement of equipment parameters, verification of factors used in diagnosis, record keeping, calibration checks, protocol optimization, and regular quality audits. These are all the program of quality assurance. This program aims to ensure equipment and procedures held in the desert diagnostic information and include administrative procedures, acceptance testing, and commissioning. Acceptance testing not only radiotherapy, also diagnostic. After the installation, there is an acceptance testing and also commissioning. And after the commissioning, you have the quality control parameter fixed, and this should be done the whole life of the machine. QC tests are used to verify the satisfactory operation of radiological equipment, and verification of QC equipment and materials is essential. That means not only the CT machine, you have the quality control program, even all the equipments you use for the quality control, there should be also a quality control program for this equipment used for the quality control. Yes. And here I go further. Follow-up corrective action is crucial, particular for safety concern, to ensure that problems are resolved promptly. Staff education, training, and continuing education are vital to maintain competency. This is actually the staff education, training, and continuing education. This should be done continuously. Do not save any money for the education. Yeah, we have the best machine, but what is the lack? Our education. So the education lack with the best machine, you cannot maintain a very good qualification. So the two things, a good machine and a good training program, is essential for a nice diagnostic department. Radiologist, radiographer, and medical physician should meet minimum competency level, and ongoing experience is essential to proficiency. Here, licensee and resistant. Here is actually 4 people. One is the licensee or a resistant. It can be a director of the hospital. It can be a CEO of the hospital. And the CEO of the hospital are not radiologists. So he transfers his responsibility to radiologist, medical physicist, and of course the radiographer. But the official responsibility lies in his hand. This is very important. Here I write here, the responsible establish a comprehensive QA program which can delegate specific tasks to qualified staff. The ultimate responsibility of fulfilling the QA program lies with the licensee and registrant. Just an example, in Germany, you should not do any CT or radiography when there is not a licensed radiologist is there. Yeah, when the weekend, sometimes it's not possible to have such types of radiologists, and some hospital they do with the assistant doctors, but they have no this licensing. So maybe there is a penalty, and this is actually responsible, this licensee, to take care that also in the weekend there should be a competent radiologist is there. A designated radiologist should oversee and ensure the complication of required care activities. Yeah, a radiologist in this case, in radiotherapy, you have medical physicist and radiotherapists. They have combined responsibilities, and both are do their work, and it is also divided. But in the radio diagnostic department, till now, some departments, they are also arranged from the beginning here, give the responsibility of physicist, the technical and physical direction, and radiologist in medical direction. But most of the hospital, the radiologist actually the responsible person, and he take care of the medical physicist and radiographer. Here you see the role and responsibility of radiologist. I go once again because also important for you to design a radio quality control in your department. Here is ensuring medical physicist and radiographer receive proper CT training and continuous education. He is actually responsible. Ensuring equipment maintenance. He is actually responsible to have a contract with the biomedical engineer of the vendor, so they come regularly to maintain the machine. Supervising and managing all aspects of the CT QA program. Actually, most of the radiologists, they give the medical physicists this responsibility again, and the medical physicists do actually such types of tasks. Providing orientation of radiographer based on established procedures. Yeah, radiographer is one of the most important person in the hospital, and because she or he actually does the radiography at the end. So all the training and possibilities should be very aware to these radiographers. Designating a primary Q radiographers and oversees their work, ensuring availability of the equipment and materials. Yes, of course, the licensee and radiologist should buy all the equipments needed for the quality test. Scheduling at adequate time. Yes, should give also the time for the quality control. Yeah, this is actually a problem in the hospital. They are so busy and do not give actually quality control time, and this should be also designed, written. Ensuring medical fees overseas equipment related, yeah, all equipment related medical fees is regularly reviewing radiographer and medical fees test result. They can combine the medical fees and radiologists combine actually reviewing the I think it is internal audits that all the values according to the laws should be done in the hospital. So very often you should do an internal audits, because you have every 2 years come from the external audits. In many countries, maybe in other time. Appointing someone to oversee the radiation protection officer. Yeah, it is actually both of them medical physicists. Even you can have a radiation protection officer, a radiographer. Yeah, I think it is better. The head radiographer can be a radiation protection officer. Maintaining and updating records in the CT QA protocols manual, providing ongoing feedback to radiographers or image quality and QA procedures. And you see here is very, very important roles and responsibility of radiographers. Radiographers is one of the main person in this radiology department. Ensuring that the appropriate protocol and technique factors are used for the requested examination. Ensuring that the QC tests are performed, interpreted, and recorded appropriately. Recording imaging problems, undertaking additional continuous education courses. Yeah, she or he, we should give a regular education. It can be an internal, you can organize an internal course where medical physicists give the lectures for the all new radiation protection laws and what it changes in the protocols or what changes in the new technology. This can be done occasionally, and of course you can send them some additional places where a dosimetry school or other institution. Responsibility and medical phases, this is for you, very important. Providing advice to the facility on CTMS quality and radiation protection for patients, staff, and public. Yes, don't forget public. Yeah, this radiation protection. Yeah, when some people come with the patient, you should also take care whether these people should be saved from radiation. Offering guidance on acquisition, installation, and shielding. Shielding is a very, very important parts of a medical physicist responsibility, and how designed a department it should be given. There are many, many protocols or many scientific work is given. You can read it and you can check such types of shielding. Conducting tests to ensure the safety and proper functioning of CT equipment, including acceptance commissioning, and of course, then the routines QC test. Advising the radiologist and radiographer and optimization strategy. I have talked many times that the medical physicist should teach the radiologist and radiographer the optimization process, how he lays dose with the proper quality of the photo. Offering oversight and advice to the radiographer involved in the QC program. Here is the outline of performance test. Yes, I have a little bit time. You see the performance test here is given. Tests are conducted on ensure the CT scanner performance, including acceptance, commissioning, and routine operational stability test. Tests are categorized and essential and desirable, with the former being mandatory, that means essential is mandatory, and the latter, that means desirable, is recommended if feasible. Frequencies vary from day, month to annual, depending on the test importance. Tolerance level for test results are defined as acceptable or where applicable, achievable. Out of tolerant results should be prompt a retest. Acceptable means performance must be within tolerance or equipment use should be halted. Achievable represent optimal performance under favorable condition. Here you see the CT performance test. There's many tests here in the first column, and second column, the person, they are doing this text, and then which facility, radiodiagnostic and radiotherapy. And you see here, CT alignment test, radiography. All are text for the radiographer. The daily performance should be checked by the radiographer, because they should take care. It is actually important that they do these types of tests so that they can also take care in the daily life. SPR accuracy, CT number, image noise, image uniformity, and image artifacts, image display and printing, external CT positioning laser, coach top alignment and positional accuracy, CT number, and multiple materials. This takes, most of them text do not need any external QC equipment. They can do this test through the machines. Even vendors give a program which can be started here. I think in 3 months you can start this program, and a radiographer, and here all the result is giving just like thickness or light, laser, everything. and this should be protocol very well. And here the CT performance test, you see here the medical physicist, your case is, most of the case is not with the equipment. Here visual inspection and review of our program, CT alignment lights, SPR accuracy, KV and half value layer. Yes, this is actually physics. This give you the perfect voltage, which is also important for the quality. And radiation dose, it is your domain. CT number accuracy, image noise, image informity, and artifacts, it is our domain. When there is artifacts, how it's coming, and you should know how it could be out. Image display and printing, this is also image display is very, very important. The display monitors and everything should be also checked monthly, even in annually. Here is continuous the medical physics, image slice width, X-ray beam width, spatial resolution, here modulation, transfer function. Yeah, this is a very important factors. You need some calculations and the course, you know, a little bit more inside the image formation. External CT positioning laser, co-stop alignment and index accuracy, gantry tilt, and CT number accuracy. These are all the works of medical physics. You see which diagnostic facility is needed and which is radiotherapy facility is needed. Here radiographer test. Yeah, now you know the responsibility from the radiographers and medical physicists, but here you see how occasional such types of test is done, and here gives also the criteria. Here I have just taken some short here snaps. CT alignment test essential. This is essential. We have also defined mandatory and achievable. And here you see the monthly. And then acceptable is plus minus 5 millimeter. This is actually law. When you have the CT elements plus minus 5 millimeters, okay. But you have the possibilities to do it plus minus 1% through a very, very good teamwork and of course the optimization. Yeah. So you have this, you have the play, you have the chance to do more about the quality. And SPR accuracy essential monthly plus minus 2 and plus minus 1. And CT number, image noise, image informity, and image artifacts. These are all here given the values of acceptable and other values achievable. And achievable is actually your duty to do a better radiotherapy department. A medical physics test. Here once again, visual inspection and review of program essential. You see all are essential, this 4 or 5 tests. And suggested frequency, here visual inspection and review of the program, acceptance and annually. After acceptance testing or some big reparation, you should do this such types of tests. There is some change of maybe the tube, and you should do such types of tests. And acceptable and achievable here also given, CT alignment, SPR accuracy, KV and HVL, accepting and after the changes. Here is the values is given in this table. And of course in this IAA, you can read very details and you can find all details there. Here is also medical phase test in radiodiagnostic. You see radiation dose, image noise, image uniformity, CT number accuracy. Yeah, for there is a tools, and with the tools you can do these parts. And here is annually after the commissioning, and of course annually, and after the commission, and annually after the commission. And here is the acceptable value, and here is the achievable value. Yes, you see the acceptable value is 20% of the manufacturer specification, but you can achieve up to 10%. Yeah, that's why earlier time without medical physicist, the department always done the acceptable table. But when you have medical physics there, naturally the department want, or it is our, that we should do a achievable criteria. It is also is not boring when you do some types of physical and experimental, which is optimization based. It will also make your life interesting. Here once again, the physicist you see here, image display and printing, image slice width, X-ray beam width, high contrast spatial resolution, and here is essential, desirable, and once again the suggested frequency, and of course the criteria. I think my time is little bit 2 or 3 minutes. I'm also finished very soon. I go 2 or 3 slides more. Phantom and equipment. Yes, here actually phantom and equipments, most of the hospital, when there is a CT machine, when they buy a CT machine, some tools is already supplied. And there is a possibility, the medical fees is there, so with the radiographers, you should do all the quality control. Or some small hospital, the medical physicist, they just oversees, and they give contract with the vendors, and the vendors come. Especially annually, things can be done by vendors, but in daily checks and monthly or 3 monthly, this should be done hospital, because when you give contract with such types of things, then they should come, and it is a cost very high. Therefore, all annually you can give a contract, and the vendors of biomedical engineer for the vendors, they come and do with the maintenance and inspection such types of experiment. Just like you should have a doses measurement phantom. Sometimes maybe it is expensive. Maybe you just give a analysis whether it is better to give them or you do and buy this machine. So here I give very quick some noise and informative phantom. You see here this phantom, some design. Here you can see the noise and informative by visual. Yeah, of course. Here then the next one, you see the low contrast phantom. Here is some how good your radio CT, then you can see there is a protocol here. You shoot how many balls you should shoot. Then the machine, when this you cannot see this as designed, then you should do some, maybe you change some parts of the CT machine so that you have again the low contrast is possible. Then the here line per high contrast phantom, here you see different types of light. There is a maybe 2,5 line parts per millimeter. This is actually is obligation, and you should see whether it can be. And here MTF, modulated transfer frequency, this can be also done, but you need some calculation and everything. Some pieces do that, but in the hospital, actually, the line per high contrast phantom is important. It's easier. And you see here also view of slice width possibilities. How can you measure? But actually, in the vendors program is included such as experiment, and the radiographer can do that. But you know there's physics, there's such possibilities there. And of course, here also set sensitivity phantom. And then here you see the laser devices phantom is also possible. But as I told you, there is a program. With this program, you can control all the parameters. This is an important for medical physics. You know this dosimetry phantom. There is some holes, and you can do the right side. Here you see the pencil ionization chamber. Yeah, it is different than the normal chambers, you know, from the radiotherapy. And with the chamber, you can calculate the CTDI, and of course, and then DLP, and the effective doses. And here is the city numbers phantom. Everybody know this phantom, Sears phantom. Yeah, Sears phantom. There is a many holes with different tissues and different materials, and you just calibrate your CT machine with that types of phantom. Here you see here. Also, you know, this is a RME ACR accreditation phantom, and this can be also used at the beginning by the vendors engineer to all the organs, different tissues calibration. And of course, here is the external lasers. This can be also checked, but it is in radiotherapy. Because in radiotherapy, you need the geometrical parameters very well. But in radiodiagnostic, geometrical parameter is not important. Important only the field size and collimation, nothing else. You have only your photos. So here is read more. I have just gives this on IA 1557, and there is another one. These are, I think, for the design of quality assurance in radio diagnostic department is enough, but you have many publications. There is no boundary. You can use everything, but this should be aligned with the laws of your country to design the quality control phenomena. So thank you so much for hearing my lectures. I hope you have learned something for design your quality assurance program, or you refresh your quality program. Thank you once again.
Thank you. Thank you, Professor Jakaria, for having a detailed quality assurance program as per IA protocols. I hope that these 3 lectures have enjoyed by the participants and they can know some things. And we have now question answer sessions. So they would like to know whether the videos is available or not. So everything you'll see in the AFOMP website, the whole recording has been provided. And individual speakers are requested, as the already engineer Entz write to the participants, then they will give their presentations to the organizers so that participation can have that one from the organizers. So we have a question. We have received very few questions. One question to Professor Jakaria, and also I think the Anss also can answer this because all of you are people from diagnostic radiology. So one question is from Rajesh Kinikar, that's the focal spot estimation or measurement from a CT scanner is always a challenge, and it never agrees with the manufacturer's specifications. So what's the best way that we can overcome that, how this focal spot measurement? Professor Jakaria.
Yeah, this is actually a complex things. Actually, on the physics, they do their experiment. They shoot. The vendors had also these values. Yeah, I do not know. Maybe Kathrin, do you know how can determine this one exactly? Yeah.
I know it is problematic, so maybe you just talk to your manufacturer to ask them what you can do to get a step-by-step instruction on how you should measure it, and maybe do it together with a technician from the manufacturer so that you can see if you're doing it right or if there are any problems, and then you can solve them directly with the technicians.
I think so. Together we determine this one. Yeah, not they do determine and we determine. Yeah, I think it's a good suggestion. Yeah.
Okay, another question, so you can both answer. That's the increase the kVp contrast will decrease, but in CT scan. So normally we use 120 kVp. So what is the best contrast resolution? And normally why we fix 120 kVp in CT scan? In the chat box, you can see also the question if you cannot hear very clearly. In the chat box, there is a question. Why we fix 120 kVp in the CT scan and also kVp increase kVp, decrease the contrast?
Yeah, actually, for the CT scan for slice, you need the hard radiation. Yeah, and this is actually with more than 100 kV is necessary. And what is the another question? There's some.
Yeah, another question is that kVp contrast will decreases, increase the kVp contrast will decrease.
Yes, that's the through the irritation process or through the reconstruction process. That's why we have different reconstruction process. Yeah, and maybe with irritation process we can increase. We have hard voltage, but through the irritation process we can even increase the contrast. That's why we have different types of irritation reconstruction process.
Okay. Okay. And anything? I do not have any more questions here. So, Jean, are you here? Otherwise, thank you, speakers and other participants. You will catch all those presentations at a time. Okay.
Dr. Jean is not here, I think, ma'am. Anyway,
Okay,
I
so
think we can conclude with that.
yes.
And
Okay, so
from
we
AFOMP like to thank you and all the speakers. And some of the participants has asked for the PPT. Entz has agreed to share the PPT. So I will email the PPT to the participants along with the certificates.
okay.
Yeah.
So thank you so
Okay.
much, and thank you so much all the participants for attending and making it an active and interactive session. And we will see you all for the next webinar next month. Thank you.
Thank you. Thank you. Bye bye.
Thank you.
Thank you.
Thank you. Bye-bye.